Welcome, everyone. I'm Jillian Gilchrist, State Representative for the 18th District in Connecticut, and I am Vice Chair of our Public Health Committee here in the state. I also co-chair the Women and Children Subcommittee of the Medical Assistance Policy Oversight Committee. My co-chair is joining us today, Amy Gagliardi. And I'm just so happy that all of you are taking time out of your busy schedules to be here for what I think is an incredibly important conversation, an incredibly important policy area that I think has been overlooked for far too long. And just really excited to get this conversation going and just to have this meeting today. So thank you all for joining. As we can see from what's been shared already, there is much to learn and much to do. And so with that, I am going to turn it over to the Endometriosis Foundation of America, who I have just been so honored to work with. And we are going to hear from Dr. Dan Martin and Diana Falzone.
I'm happy to jump in first. It feels really great to be in this company, but to hear so many of you that have endo, it's almost like you can take a sigh, because it's almost like you don't need to explain it. You know, I know, we get it. But my goal, and I know your goal, is for others who can facilitate change to have empathy and compassion and the ability to make a difference. In 2016, I was 32 years old. I always suffered with bad periods, always. Ovarian cyst bursts, and my mom would take me to my general gynecologist, and they would say, oh, you know, that happens sometimes. That's normal. My mom said, really? This is normal? Okay, well, give her a birth control pill. So my mom said, okay. Not one time were we informed or educated about the possibility of an illness called endometriosis. So for years and years, I sucked it up because that was what I was told to do. This was part of being a woman. This was part of the cycle of the journey. It wasn't until I was 32 years old where I got so acutely sick and sent to an ER where a general doctor really dismissed me, said I could have the flu or a hormonal imbalance, that I was sent around to many different physicians until finally I got put into the hands of a specialist who said, I think you might have endometriosis. And I thought, well, hold on, what is that? We'll let Dr. Martin explain that later. But then she said, and you know what? I want to do a blood test. I want to check something, because sometimes endometriosis goes hand in hand with egg reserve. So I thought, I'm 32. My 33rd birthday was fast approaching, about a week away. Did the blood test. It was called an anti-Müllerian hormone test, an AMH test. It tests the egg reserve that you currently have. Relatively accurate. Well, before I even knew I had endometriosis for sure, I got a call where my doctor told me to sit down, which is never a positive thing. A doctor says, hey, are you alone? Can you sit down? I got my notepad and a Sharpie because it's all I could find. And she said, I don't have good news. Your AMH is 0.07. And I thought, okay, in layman's terms, doc, what does that mean? And she said, what that means is that you are infertile. You're not sterile, but you're infertile, which means getting pregnant naturally is virtually impossible without in vitro fertilization assistance. At this time, I was career-oriented. I wasn't thinking about having babies, but I certainly had that in my future life goals and never thought that I would be robbed of that opportunity or that option. So she said, but before we worry about the babies, let's focus on getting you out of pain. So it was then I had my first surgery. What I didn't know is that only within a year of having excision surgery, which is considered at this point in endometriosis to be the gold standard, I didn't know that there was a possibility if any endometriosis was missed, not seen, even on a cellular level, that it could come back. I also didn't know that not only did endometriosis and infertility sometimes go hand in hand, but that it could be extrapelvic. So I ended up having my appendix removed because of endo, an ovary removed because of endo, And at my third surgery, unfortunately, 3 surgeries, because I didn't have early intervention, I have an advanced stage of endometriosis. I had my kidneys actually at extreme risk. And if I didn't get into the right hands of a specialized surgeon, my surgeon being Dr. Tamar Sechkin and Dr. Goldstein, I wouldn't have been able to necessarily have my kidney function because my ureters were encapsulated by endo lesions. So I think one of my goals of this working group is for us, and I mean this collectively, to get out of this idea that endo is simply bad cramps, that endo is a benign disease. Endometriosis not only can rob a person of their planning of their future, many days of their lives in crippling pain, but it can also compromise their overall well-being. There has been women that lungs collapse from endometriosis, who lose part of their stomachs and have had part of their bladders cut out, who suffer with incontinence. There's so much more to this disease than bad period cramps, and it's severe, and it should be treated as such, and it should be given the attention and the funding in order to make a real difference. And we're just starting our work here in Connecticut. So again, thank you all for listening to my story, because it's simply reflective of so many other people's that have endo.
Thank you so much, Diana. Dr. Martin?
Thank you. What I'm going to do is review some of what's already been said, add a little bit more, give you 4 of the needs that are commonly recognized, and then turn it back over to you to see what needs this group wants to discuss. So, as many of you know, endometriosis is a condition in which tissue like the normal lining of the uterus grows outside of the uterus. It's not supposed to grow there, and the body knows that. So if the immune system is competent, it can inactivate the growth. However, in many women, the immune system is not competent. The endometriosis continues to grow, cause inflammation, and is associated with scarring, pain, infertility, nodules, and cysts, and all the problems we've heard discussed this morning. As we've discussed, these problems need proactive and focused attention. Women with infiltrating endometriosis due to long delays in diagnosis associated with the normalization of female pain, that is, everybody tells you it's normal. That is a societal problem. Patients tell themselves it's normal, their mothers tell them it's normal, their sisters tell them it's normal, their peers tell them it's normal, and worst of all, their providers and physicians tell them it's normal. And although we should hold physicians and providers to a higher standard of care than we hold the rest of society, they're still part of society. So this is a societal problem, not just a medical provider problem. There is a lack of awareness and a lack of access to a multidisciplinary approach that can combine surgical, medical, and complementary care. We need this facilitated by increased awareness of the normalization of pain and of this hidden disease. At the same time that we need to avoid long delays, we also need to remember that early surgery is associated with increased repeat surgery. There's no easy answer to this. Moreover, when the immune system controls endometriosis, it can be found incidentally on an exam or during surgery for other reasons. Although these inactive forms are the least commonly discussed, they may give us the most information that can be useful in the future. The body's immune and reparative ability to inactivate endometriosis suggests a pathway for therapies that can help future patients avoid the morbidity suffered by current patients. While there are many needs, I just want to review 4 some of which have already been reviewed today. The normalization of pain is associated with delayed diagnosis and the need for complex and deep excisional surgery. We need an increased general awareness of the normalization and of pain as an invisible disease so that we can limit the progression. Insurance coverage of and access to complex endometriosis surgery is limited. We need better access to endometriosis centers of care and improved insurance coverage for complex endometriosis surgery. Proactive medical treatment may avoid or limit the need for surgery in the future. We need additional data on proactive medical treatment to see if this is correct. The need for surgery for diagnosis and treatment is expensive and morbid. We need to develop non-surgical tests for diagnosis and research on early endometriosis. Thank you, Representative Gilchrist. I'll turn it back over to you.
Fantastic. Thank you, Dr. Martin. I'm going to open it up to the group for questions for both Diana and for Dr. Martin. I will start. My questions have to do with just this last week in speaking with someone who's experiencing endometriosis. It was the first time I heard the stages. Could you talk a little bit about the stages associated with endometriosis?
Okay, the stages we have, I forgot, I counted one time how many staging systems I could find, and it was going into 30 or 40. The most common that's used is the one for the American Society of Reproductive Medicine. The American Society of Reproductive Medicine has 4 stages, and these are based on the degree of endometriosis that is seen, its distribution, and the adhesions. However, the stages don't predict, except for if you look at stage, so David Adamson in California and Michel Keny in France have decided there should be a stage 4B. And they use the ASRM's stage 4 with a score of 72 and divided into 4A and B. And A is anything less than 72 and B is greater than 72. Anything greater than 72, you don't get pregnant without IVF. So really high scores need IVF. Anything less than 72, it depends on how well it will respond to surgery. In terms of pain, the staging is not predictive of pain. Although there are certain characteristics that are predictive of who will respond to surgery, there are no characteristics that predict who's going to have pain. So if we have someone who has a focal area that's tender, that means that they can point to the tenderness. We can find a nodule where the tenderness is, and that nodule can be seen on imaging, then surgery has an excellent chance of curing the pain. On the other hand, if there's diffuse pain, and when you do surgery, there's focal lesions, surgery doesn't respond well. It's one of the reasons that people who do lots of surgery would much rather operate on bowel, even with a chance of colostomy, than operate on small areas. Because operating on bowel lesions is one of the most successful things we have for pain. Even patients who have colostomies usually appreciate the surgery because they get pain relief, and because the colostomy is usually a temporary one and is put back down and repaired in about 3 months.
Thank you. My second question has to do with the diagnosis. I've been fortunate now to have these conversations, but just for folks watching and for anyone joining us today on the working group who's not so familiar, can you speak more to, you gave it as a recommendation, but what right now, the surgical diagnosis, can you speak more to that?
So the way we generally diagnose endometriosis is to do what is called a laparoscopy, which is a belly button surgery, where telescope-like instruments placed through the belly button so that you can look inside the abdomen. Endometriosis commonly looks like dark scarred lesions, but it can also look like small pimples, clear lesions. It has multiple appearances. Some endometriosis can hide behind the peritoneum. The peritoneum is the lining of the abdominal cavity. If it hides behind that, it can't be seen at all. Some endometriosis, if you have to do a laparotomy to be able to palpate it, and we're not sure we know how to recognize all endometriosis. The most important lesions, though, are the ones we talked about earlier, which are the large nodular lesions that you can feel, and those are generally easy to see. And those are the ones that most commonly respond to surgery. What we would like, though, is something that we do not need surgery to make a diagnosis. We would like to develop markers, immunologic markers, histochemical markers, something that we can use that will give us the ability to diagnose endometriosis before we do surgery so that we can plan better. And even more important, or as important, would be that we have markers so that we can do research on what is effective for endometriosis other than surgery.
Thank you. I'm now going to open it up to the group. If you could use your share hand feature to raise your hand to ask questions of either Dr. Martin or Diana Falzone.
While everyone's organizing their questions, let me say hello to Danielle and remind her she should say hello to her father for me. He and I have written papers together in the past.
Of course, Dr. Martin, it's always a pleasure to see you.
So I see that Sarah Fox has raised her hand, followed by Siobhan.
So Diana and Dr. Martin, my question is specifically around the advocacy policy work you went through and underwent to get new policies passed in New York State. I'm hoping that we can move forward with something similar to that in Connecticut. So what are your thoughts and methodologies to actually get that accomplished?
Is Jean also still on the call with us by any chance? Because she's been instrumental in helping with legislation.
Is who?
There you are.
Oh, yeah, no, I'm here.
Okay.
So I like to tell the story. So Dr. Sechkin, we've been talking about it for years, and he took a day off and we went to Albany and we met. We decided we were going to meet with all of the elected officials on the education and the health committees, and we did. And we met with their staff, and to our surprise, about 2 weeks later, we found out that one of them that we had met with, New York State Senator Sue Serino, had introduced a bill, and that it was bipartisan. She'd reached across the line to the Assembly, and Assemblymember Linda Rosenthal and her, they had worked to repeal the tampon tax in New York State successfully. And so they started us on this journey. And it took us about 2 years, and former Governor Andrew Cuomo signed it into law November of 2019. What it is, the law requires the commissioners of education and health to create materials about menstrual disorders that include endometriosis that will be available to schools, medical practices, and other organizations throughout the state. And we have an Empower program, and it was an education kit, and we are going to be relaunching it. And we were doing it in schools through pilot programs, but we realized that really the best way to do this is to go to the states where curriculum and education is best managed and distributed. So that's how we started that. And so we now have just created a toolkit, and then we're going to be working on the ground level to help groups like this group in each state to decide what is going to be the best type of legislation and what kind of recommendations they want to have, and then work with you to get that through and support it. So we also, and I will say, we also work with the House Endometriosis Caucus. So we are working on the federal level, where we were able to double the research funding with former Congresswoman Abby Finkenauer and some of our other endo support groups. And we were able to double funding to $26 million, which we are optimistic is going to be maintained this year. But we're talking about originally $13 million, which was just not enough. So we are working on that level as well, and we will continue doing that. So we will be notifying you of some of the coalition building and work that we'll be doing on that level as well as they happen simultaneously.
Fantastic, thank you.
You're welcome.
Siobhan Feliciano.
Well, thank you. You know, and just thinking about the timing of this meeting, recently, I don't know if anyone else follows that comedian Amy Schumer on Instagram, but very high profile. She was recently diagnosed with endometriosis and had some surgeries and is really taking this on as her cause to bring awareness. And I'm wondering if there's any recommendations for how we can sort of harness some energy too in our state. It's nice to have a celebrity bringing attention, but just for public awareness, like what works and where have you found momentum before in sort of garnering public interest in the topic, and how can we sort of drum up some of that?
I think op-eds are really powerful from people that have the disease or have a loved one or something that has made them passionate about the disease. I know for me, I'm a working journalist, but first and foremost, woman with endo, and I use the power of the pen, so to speak. Anything, even when we went to Capitol Hill and we testified, I was there to advocate. I think the more voices you have, the better. If you can get something in a local newspaper or publication, even this today is really great, because you just don't know who's paying attention and might have some ability to pass something through. So I would say go to the media. I mean, the media is really where you're going to be speaking truth to power. So pitch.
And I would like to add that Diana has been a strong advocate for many, many years for us. And she did go and do a congressional briefing on Capitol Hill with Dr. Sechkin. They met with several of the staff up there. Our co-founder, Padma Lakshmi, has done the same. Diana, they made phone calls, they wrote letters, they, whether it was on the state level or Capitol Hill, we used petitions. They reached out and used their platforms to garner those signatures. So, I mean, their passion and the utilization of their platforms was extremely helpful. And, we can't thank them enough for doing that. But also, I think to your question about celebrities, and yes, they can bring a much larger platform immediately. And so it's wonderful to have them. And many of them are supportive of more awareness and education.
Great. Thank you. Brittany Decker.
I just wanted to add to that. So somebody with endo, I found that I get a lot of support through like social media, like Instagram. There's a lot of groups and individuals on there that talk about it. And they kind of has created a community for me. So that may be a resource to create awareness, is there are people out there like on these platforms that are already trying to create awareness. So maybe involving them and getting the word out within these communities as well that are already kind of set up.
Wonderful. Thank you.
Yep.
Yeah, just from doing this for the littlest bit now, compared to many of you, I've been pleasantly surprised to see how many groups there are and folks trying to raise awareness on the various social media platforms. Any other questions for Dr. Martin or Diana Falzone before we move on to our final part of our agenda? Well, they'll continue to be with us. So if you do, great. So now I wanted to move into a conversation. And so again, please feel free to use your raised hand feature, only because we're not in person and I can't see folks. Want to have a dialogue. I've heard some great things already and I took some notes. So I'll share. Maybe I'll start with. So as you know from the email I sent out, what I'm hoping to do is have this group meet every 2 weeks through January, at which time we'll make recommendations to the legislature. This year we are having our shorter session. So it starts the first Wednesday in February and runs through May. And so what I'd like to hear from you all is, what are your thoughts on future presentations, conversations, information you would like at these additional meetings? We will meet every 2 weeks on Mondays at 1 p.m. to keep it consistent. However, our next meeting will be on Wednesday, October 13th, because here in the state of Connecticut, we have a state holiday for Indigenous Peoples Day on Monday, October 11th. At this point, I've written down some notes based on what folks have been saying. I'll start with Lakeisha Rivera, what you had said. I've been saying to folks, what struck me is that, I don't think this should happen to any woman, and I've just been horrified that it's taking this long. for folks to be diagnosed, and then to hear Dr. Martin talk about the normalization of female pain. I hadn't heard it framed that way, but couldn't agree more. I think that's what it is. And but what really strikes me is that the women I've heard from are women who seem to understand that they can advocate for themselves. And so what about women who are already disenfranchised in the healthcare system? So I would love to have at least one, but a few conversations on our understanding of endometriosis and how it impacts Black and Brown communities. I'd be interested in the piece about breastfeeding and endometriosis. I didn't know until today about the genetic piece. So it would be really good to understand, is this passed on from generation to generation? Interested in, again, a future conversation about increased awareness, increased insurance coverage, access to endometriosis care, and then information. I know we have some amazing researchers with us on what's being done to try and diagnose endometriosis before you have to do anything surgical. So those are some of the things I've taken notes on. Please feel free to jump in and talk more about what I just said, or anything else that's striking you that you'd like us to focus on. Amber.
So I think another big, I don't know how you feel about it, but PCOS is another big reproductive health issue. And so I feel like if we're going to target, one of my thoughts is that we should target education in schools, and also, have some sort of screening like they do for preteens, where they screen for depression up until adolescence and so forth. And so if we have some sort of screening tool that we can implement in like pediatrician's office or even school nurses, because they do see a lot of females who come in for supplies for periods or just really bad cramps. But with that screening tool, not only being able to target endometriosis, but also being able to target other reproductive health disorders like PCOS, because again, with female pain so normalized, PCOS goes undiagnosed pretty much as often as endometriosis. And so I do think that there will be a lot of overlap in that, but I just want to bring it to your attention as well.
Can you tell us what PCOS is?
So PCOS is polycystic ovarian syndrome. Basically, these women are more prone to ovarian cysts. They tend to have hormonal imbalances. There's usually rapid weight gain, and this weight that they gain is usually really hard to get off, and it can eventually, in these women, lead to other health issues like diabetes, for example.
Great, thank you. And just so everyone knows, I'm taking notes, and we'll get all these minutes back out to folks. So thank you for the recommendation. Liz Gustafson.
Hi. So I just wanted to, I think it's like a question, and I think something that's really important to talk about in this space. So if it takes, like up to nearly a decade for most patients to receive a diagnosis of endometriosis, and, impacting 1 in 10 people who are assigned female at birth, I think it's really important that we also talk about the barriers for LGBTQ plus folks when accessing medical care, and how a diagnosis can take a lot longer for folks, because it's not just a cisgender woman issue, and it's not just a women's illness, but I think it's really important that we also talk about this as a queer and LGBTQ issue.
Great, thank you. Good points. Brittany.
A couple of things I was hoping we could address would be the pain management that a lot of us have to experience. There's every day, sometimes every day you're in pain, and alternatives to just get through your day, I think is really important to talk about. And I think it's important that we focus on nutrition as well. I know that there's been things out there that show reducing certain foods that create inflammation can help with endometriosis. So I don't know if we can get like a nutritionist in who specializes in that to kind of emphasize that side of it as well. And maybe like alternative pain options. There's not all of us, I don't know, like some people have a hard time taking painkillers every day if you want to work every day. So alternative options for pain, I think, is something we have to talk about as well, because it's, we got to live our lives too.
Yes, very good point. Thank you.
Mm-hmm.
Amber, your hand's still up. Is that just from before or another point?
Another point.
Great.
So I know we touched on it a little bit earlier, but talking about the disparities in people of color, and this was a big point that was brought up during COVID. There was a video that went viral of some woman who was complaining of a lot of pain, and the doctors weren't really listening to her. And unfortunately, she eventually died. And so what's been found since then is that people of color, their voices aren't, obviously, as we know, their voices aren't heard as much as we'd like to hear them and should hear them. And so when it comes to pain, especially, I think in the research I've done, Hispanic women they're like at the bottom. No one really listens to their pain, and so it gets ignored a lot. So I think we do have to focus on that aspect as well.
Wonderful. Thank you. We have an organization here in the state, for those who don't know, Health Equity Solutions. While they were not able to participate, I believe capacity-wise each week, I will circle back, and it'd be great if they could potentially give a presentation, maybe along with others. But I think that could be really great. I see that we have a few comments, and I should have mentioned, additionally, please raise your hand if you have thoughts of who else should be at the table. It has been suggested that someone from the American College of Obstetrics and Gynecology. I did reach out to them. I'll circle back. So yes, I'd love someone from ACOG to be here at the table. Amy Gagliardi is saying, would like to have a conversation about expanded coverage for surgeries and endometriosis care for both private and public insurers, as well as gather information about how it's covered in other states. I agree. I think that'd be fantastic. And then Rachel Graves is saying, I agree with the LGBTQ plus community inclusion, including inclusive language, and any information that's passed on for educational purposes is something that's so small and easy, but can be so affirming. Agreed. Wonderful. Liz and Brittany, hands are still raised. Do you have additional comments?
No, sorry.
No, that's okay.
Sorry.
Rachel.
Hi. So I would also like to see included in educational information the possible symptoms and side effects and other diseases that can tend to go hand in hand with endometriosis. For example, thyroid issues are also a huge thing. That's one of those things that I unfortunately didn't know about. And my doctors never had me tested for thyroid issues. And it turned out that I was living for multiple years with really nasty thyroid issues. And I thought I was going crazy. So I think it's also important to kind of focus not only on the symptoms and the effects of endometriosis, but also the diseases that can go hand in hand with them.
Wonderful. Thank you. Sarah.
I would also add adenosis. I was diagnosed with that as well. That's endometriosis within your uterus. So I had a partial hysterectomy, and many women suffer from that, and it's something that doesn't often go undetected, and it's a part of living with endometriosis. And I believe one thing that would make our state a lot stronger in this area is a standardization of care amongst providers so that they're actually speaking a similar language. Right now, when I go to any doctors, and I believe many of the individuals suffering from endometriosis share this with me, the conversations vary so much, and it could be like really sharing that you're in immense pain, saying, I live with stage 4 endometriosis, and being told, you should just take pain relievers. There's no way for us to treat you, which leads to despair, loss of hope, and just, a mistrust in the medical community. So having doctors, nurses, medical practitioners in Connecticut have an aligned shared vision for what endometriosis means, and having these conversations amongst themselves and being at this table would really go a long way to further the care for women living with endometriosis.
Thank you. Great recommendation. What is the term you said? I didn't get it down. Endometriosis?
Adenosis. If I'm mispronouncing it, Dr. Martin, please correct me, but I believe that's exactly how it's spelled.
I'm gonna put it in the chat line if I can find chat.
Okay. Thank you. Can you, since we're on it, can you explain what that is? Dr. Martin? Yep. I'll let you chat and then, yeah.
Okay. So adenomyosis is similar to endometriosis. Both have to do with tissue that's similar to the inside lining in the wrong place. With adenomyosis, it's inside the muscle of the uterus. With endometriosis, it's outside of the uterus. Lots of studies on adenomyosis suggest that about 90% of adenomyosis is because the glands that belong inside the uterus actually invade directly into the muscle. There are a few studies that suggest that there are other ways of doing it, but we have a fairly good feel for why adenomyosis exists. Endometriosis theories are all over the place. It's much more difficult to try and determine, to clarify why endometriosis gets where it gets, because we think about things like retrograde menstruation, congenital anomalies, venous dissemination of tissue, venous dissemination of bone marrow fat stem cells, peritoneal tissue turned into endometriosis. There are lots and lots of possibilities there. But adenomyosis, when it's within the muscle wall of the uterus, is there are some surgeries that can remove adenomyosis from the uterus, but they're very controversial. And by and large, once it's in the muscle, the only good way to remove it is a hysterectomy. That's a controversial thing if you talk to the physicians who do the surgeries where they actually go in there and focally remove it, they'll tell you that I'm wrong about that, but I'm not sure that some of that research is the research on that is so focused to the specific people who are doing it and who benefit from doing it, that it's hard for me to understand exactly what they're doing. When I tried that in the past, all we did was get into trouble. So hysterectomies are about the only thing I know that really work. Hormonal suppression can sometimes decrease the stimulation because it stimulates just like endometriosis.
Thank you.
Yes, and I think Jean's put in another link in there, so the word is in there and the link is in there now.
Fantastic, thank you. Dr. Luciano.
Yeah, I just wanted to comment on the standardization for physicians. I really think that, it is very important, obviously, to educate the public and to educate our patients. And I think the screening tool for pediatricians' offices and nurses' offices are wonderful. I mean, I just brought my daughter to the pediatrician, and the only thing they asked her about was depression. And we have a family history of endometriosis on her father's side of the family. I wish that they had asked those kinds of questions. But I think it's also important that we educate our physicians about endometriosis. I really think that the things that are said that are not, that dismiss women's pain and that are very disconcerting to our patients is really a lack of education. And more importantly than that, lack of their ability to fix the problem, right? If you don't know how to fix the problem, then it's hard for you to offer anything to the patient. And I think as physicians, we're so afraid to not know something sometimes that we dismiss it as opposed to talk about it or offer them opportunities. So I think if as a state, we can also promote these physicians or encourage these physicians to send patients to doctors who know about endometriosis, we can fix this problem faster, right? So don't make these physicians feel like they're losing out by referring their patients, make them feel like they're doing the right thing.
Thank you. Fantastic point. You're making me think. So prior to becoming a state representative, I was the director of health professional outreach at the Connecticut Coalition Against Domestic Violence, very long title. But what that work was, is I would go and train health providers to screen for intimate partner violence. And what I found time and again is that the reason health providers weren't doing the screening is because they didn't know what to do if there was a positive, if someone did say that they were experiencing it, because they didn't know what to do with the patient. And to your point, they didn't feel like they had the know how to solve the problem. And so it was just training them like, no, you don't need to solve the problem. Right. Please just make the referral. Like, please make the referral. Yeah.
No, exactly. And I totally appreciate that, because that is something that like has happened to me before, unfortunately, with the same kind of thing with partner violence. And thank God we have a social worker that's like right down the hall from us, who I just excused myself from the room and ran down there and was like, give me stuff, you know? But it's really important. And I think that's what's happening. I really do. And I think it's our responsibility to educate the physicians and make them feel comfortable referring and feel like that's the right thing to do.
Fantastic.
Give them tools.
Yeah. Sarah.
I really appreciate that. I would say that just throughout the course of my treatment, there were so many things that were isolated, and they were isolated for me. And I'd go to doctor after doctor, and it was really, you know, it might appear as like a gastro problem, IBS, urinary tract infections, but they are things that if there were a screener for adults as well, that, you know, when you combine them all together, you actually begin to see like, okay, so these are things that women that live with endometriosis live with. Like, this isn't just like it's not really all in isolation. And so for me, it was really powerful when I received my diagnosis to understand like how everything was connected. And I think so thinking through a screener so that doctors can be prepared in that way as well. Thank you.
Thank you. Amy Gagliardi has made the comment that it would be great to have someone from the Connecticut Hospital Association and the State Medical Society participate, so that we can spread this to additional providers, this information. I think that's a great idea. So we'll reach out. Amber.
So I have my nursing background and also the political science side. I have a second degree in that. So I'm very active in lobbying and advocacy because I feel like it's so important, especially as a nurse. And so as I was coming out and telling people that we were starting this group, I've had a few women reach out to me, and they suggested that along with education about these different disorders, that we also teach, like once teenagers and preteens start getting their periods, we teach them to start cycle tracking. It's not going to be perfect, but it might be able to help us detect signs of reproductive health disorders earlier than we are now, because, you know, periods are still a very taboo subject. And I feel like there's not a lot of education in a health class other than, you know, you're going to get your period and you can get pregnant and all of that, but no focus on the actual issues with reproductive health.
Great. Thank you. Okay. And for folks to know, through Janet Alfano, I was connected with a young woman. I'm going to get completely wrong what school she's with, but she's been doing quite a bit of advocacy in Fairfield County with regards to period shaming and ending the stigma. And so ideally, we can engage her, and she has outreach to younger folks. So I think we could tie that piece in too, but I've made the note. So thank you, Amber. Additionally, in the chat, Sarah's saying include someone from the State Department of Education. Great idea. We'll reach out to them as well. And then the Endometriosis Foundation of America, thank you, Jean, has put a link to the New York law. And we can, my legislative aide and I will follow up with these notes to everyone and these links. Any final comments or thoughts for this first meeting? Well, I really do thank all of you for being here today. Those of you with amazing expertise, those of you sharing your experiences and using your experience to ensure that others don't have to go through what you've gone through. I really look forward to robust conversations as we head towards January. A reminder, we will meet, our next meeting will be Wednesday, October 13th at 1 p.m., again via Zoom. And then we will be meeting every other Monday. So the meeting after that would be Monday, October 25th. Sarah is also asking, can we share the statewide toolkit so that we can review in advance of our next meeting? Is that possible, Jean? Is that toolkit ready to go?
Yes, we should be able to share that with you. Yes.
Awesome. Okay, great. We're also going to be sending out the Outlook calendar for all of the additional meetings so that you can have those in your calendars if that's something you use and is helpful for you. And we'll send out notes from today's meeting. As you've heard, please, this was on Facebook Live today. Please feel free to share the link and raise awareness on your social media platforms, since that's a great way to get more folks engaged and understanding the issue. And if you have any questions or comments between now and our next meeting, please feel free to send me an email. Thank you so much for today. I look forward to working with you all.
Thank you.
Thank you.
Thank you.